Good morning, Susan. Can you hear me and see me okay?
Yes, I can.
Give just a minute for Dr. Merman.
It looks like Pat might have joined the
Yeah,
executive session. Are you checking with her?
I was just gonna text her. I'll
I
get her
Thank
back.
you.
got it, Robin.
Okay,
I got
Thanks,
Thank you.
Michelle.
Sorry about that. My Teams just crashed and came back.
Great. Good morning. Okay, I'll call to order the Green Mountain Care Board's meeting of May 6, 2024. We have a continued presentation on the AHEAD model and the Vermont Medicare Global Payment Design. It'll be presented by Elena Barabee and Shule Garavich. And we have minutes from April 29th. And I will move to approve the minutes from April 29th.
I'll second.
All in favor of approval?
Aye.
Aye.
Aye. And the minutes from April 29th are approved. And I will also move approval of the minutes from May 1st, 2024.
Second.
All in favor, say aye.
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 Aye. And the minutes from May 1st, 2024 are approved. And with that, I'll turn it over to Ms. Barabee and Ms. Garavich.
All right, thank you. Good morning. We'll share the screen. And we are continuing the conversation that we started a number of weeks ago. Can everyone see the slides? Great. So I'll just breeze through some intro slides again and then pass it over to Dr. Garavich. So we'll kind of do the public session on most of the remaining content, and then we will discuss negotiation strategy. If there's time, we have a big chunk this morning, so hopefully we'll make it there and be able to solicit some of your thoughts on that. So here's a revised calendar. As you know, we've been going through this material for a number of weeks now. It's very dense, and so we've been kind of revisiting some of these details with more depth. And then today we'll hopefully finish some of the performance adjustments that we haven't covered yet, talk about critical access, hospital-specific considerations, delivery system reform, hospital transformation funding. And I think we'll kind of circle back to some of the questions that were raised last week on total cost of care and intersection with a Medicare global payment. I just wanted to highlight some things that are coming up that are related to this discussion. So on May 15th, we'll have a provider panel to weigh in on kind of their thoughts on the model and hospital global payment. We expect our contractor Mathematica to deliver a near final methods paper to the board around May 20th. So this should be incorporating all of the feedback that we've heard through these meetings to date. And then on May 22nd, we are working on pulling together an expert panel on value-based care and payment delivery system reform, and hope to hear from some of the other states that have done similar or as similar as possible work to see what we can hear from them in terms of lessons learned and any recommendations they have for us. And then a special public comment period for the methods paper will be open May 21st through May 28th. Of course, anyone can make public comment anytime. This is just, once we've posted the paper for folks to see it. And then we will have a board discussion and potential vote on May 29th with a drop dead date for a vote on June 5th. And just a reminder that we have to have the methods paper done so that we can then work on the specification document, which is kind of the nuts and bolts of how it would be calculated by July 1st. So that is our current timeline. Again, while this is an ongoing conversation, we hope to kind of submit this methods paper. It's not 100% done deal. A lot of things can change in negotiations. So as we learn more and do more analysis, and get into the weeds further, and that can evolve. So while you have this submission deadline of July 1st, there's really until June 30th when the state is expected to sign kind of the state agreement with Medicare, that there could be further adjustments. Okay, and now I will pass it over to Dr. Shuley-Gerovich. Happy to run the slides. Okay.
Thank you, Elena. Could you hear me okay? All right. Apologies for not having video. I'm traveling, so not very convenient place. Before we get into where we left, there are a few things that we had discussed, and I think board member Jess Holmes had asked us to recalculate the included revenue, so I wanted to start there this morning. The change in the estimated global payment revenue comes from correction of the Medicare revenue. So in the adaptive, if you remember, there was about $700 million revenue reported as Medicare, but further investigations indicated that some of it is Medicare Advantage and some of it could be patient portion of those revenues as well. From claims revenue, we corrected that Medicare fee-for-service estimate, and also run the exclusions based on the CMS method. So that reduced the Medicare fee-for-service revenue to 14% of the total net patient revenue, including fee-for-service fixed payments as well. Because a lot of it went to the commercial bucket, the last line, the potential included revenue under global payment changed slightly and not significantly. So right now it's at 66% of the net patient revenue. If everything is included on the commercial Medicare Advantage, with exclusions we have on the Medicare side, we are looking into 66% of the net patient revenue potentially be included in the Vermont global budget. The next slide, please. So if you're interested in the other numbers, we included the slides that are supporting it. 691 million, this is fiscal year 23, is the total estimate of Medicare hospital payments. And from there, you see that the 65% of that total payments would potentially be included in the global payment. Most of that exclusion is really patients and secondary payer payments. The additional inclusions CMS methodology has are outliers, subunits, and outpatient carve-outs. Next slide, please. And then there's updated number here, so included revenue for 129 million, and then you do see the growth rates hasn't changed from last time I presented. Next slide, please. So now going back to where we were, so I like this slide to put so we see where we are. We discussed the baselines. We discussed medical inflation and utilization adjustments last time we met. So we are starting from after utilization, we have social risk adjustment and other adjustments. So hopefully today we can get to the end of the adjustment conversation. Next slide, please. Social risk adjustment is the purpose is to provide additional funding to hospitals who are taking care of the most disadvantaged patients. The CMS methodology provides up to 2% additional funding to these hospitals on an annual basis. So the hospital with the highest social disadvantage score is going to get 2%, and based on their score, other hospitals will get something less than 2%. And the other adjustment that we wanted to also discuss is the CAW adjustments. For CAWs, the requirement is that they will move away from cost-based reimbursement, and the CMS methodology has a floor concept. So they are going to track the last year's cost based reimbursement amount. So fiscal year 2024, whatever that amount is, will be tracked forward, and that will become a floor in the CMS methodology. So if the global budget is higher than the floor, they are going to receive the global budget. But if the floor is higher, they are going to continue to receive that level of revenue for the duration of the program. Next slide, please. There are considerations for the social adjustment, so I'm going to go through them one by one. First, how do we measure social risk? CMS is using a measure called Area Deprivation Index. And at the beneficiary level, they are looking at the dual eligibility status, Medicaid and Medicare together, and then Part D low income status as well, to calculate the proportion of revenue that is related to these patients. In Vermont, when we had TAG meetings, we had series of discussions and very helpful conversation about the measure selection. And we had considered to use Social Vulnerability Index instead of ADI, and I'm going to get to it in a minute. And also continue to track Medicaid enrollees as the CMS methodology. As a national program, CMS is going to measure the most deprived, like the highest score hospitals, with a combination of state and also a national distribution. And as a potential consideration for Vermont, we could only look at the statewide averages and look at the top hospitals based on the statewide average and potentially distribute revenues more than what CMS is going to do. The calculation is a combination of the geographic area and the patient scores. In ours, what we are proposing is to calculate the social vulnerability score at the patient level that the patients are seeing. And that way we can align it with another adjustment that they have, which is the health equity bonus. So rather than looking at the geography, so in our case, HSA, we will be looking at the patients seen by that hospital, calculate their social risk score, and then aggregate them to see how one hospital compares to another hospital. On the adjustment side, we hadn't discussed this with the tags. If we can align with the CMS, CMS methodology is going to give up to 2%. But what they are going to do is they are going to recalculate these scores every year. And we had done some analyses looking at the SVI score in 2018 and 2019, and they haven't changed much. Because of that, we propose that to simplify the calculation, we would like to propose to recalculate that in every 2-3 years, and also align the maximum amount to 2%, similar to the CMS methodology. So if you are considering what is the difference between ADI and SVI, here is a SDOH domains and the measure sets that they use. Social Vulnerability Index uses more measures than the ADI, and there's been recent literature showing that the ADI is really impacted by the home values, and a lot of the researchers have been requesting that the CMMI reconsiders using ADI. But CMS has been using ADI in all other programs as well. So my guess is that's why they continue to use it in the AHEAD model as well. The other issue with ADI, very specific to Vermont, is that the ADI measures are done at the census block level, and the census and the results at that smaller geography are not reliable for a state like Vermont, which is rural and less population. SVI does this at the a little bit higher geographic level at the census tract, which may increase their stability and the measure specifications. And SVI is developed for CDC, kind of estimating the vulnerabilities during the emergency events. And it's already been used to distribute funds from the CDC to support public health programs. So ADI is used by CMS, SVI is used by CDC. As we look at ADI, we also notice that the rural areas are not reflected in the ADI as good as the SVI measures have done. And here is the map of the SVI and ADI. It is difficult to do comparison head to head, but at a highest level, you can see that they produce similar results, but there are some differences as well. When we look at the zip code level data, we did see that some zip codes were classified as high vulnerability in SVI, and then but in the ADI it does show up as least disadvantaged. So there is some distinction in the way that the geographies are classified between the two measures. So here, if I guess you'll take a look at the colors as you review the slides, but the red
Julie?
ones are. Yep.
Right, this is Tom. Sorry to interrupt. Do you have, or could you provide a breakdown of the zip codes that switched?
Yes.
So
yes,
what proportion appeared more vulnerable or less vulnerable when you compare those two?
Yes, we could share you the zip codes or the block levels. If I remember, like the correlation between the two was about 60% or so.
Okay.
We have done similar analysis in California, and California has the same thing, that they are not really, they are correlated, but not as strongly as you would think they would be.
Right, and I understand, and I'm wondering if there's a trend toward does the SVI categorize our population as more vulnerable than the ADI or less vulnerable? Is there a trend in when there's not a match? Is there a trend in which direction the SVI pulls things?
Yeah, we could do that as well if that's what we just compared the zip codes just to understand the geographies. If we pull the population, then we can estimate the differences like you suggested, but that will take a little bit of time. Yep.
Thank you.
Okay, so those are annual adjustments. So now we're going to move to performance adjustments under the new model. So next slide, please. The first one is the quality adjustment. So these are in the CMS methodology. As you know, CMS already has quality adjustments for hospitals, and the AHEAD is going to continue to make those adjustments based on the scores calculated and the amounts kind of applied to fee-for-service hospitals. In the Vermont methodology, we may consider to develop an all-payer approach. We do have to have a quality adjustment, so we could start with the CMS programs and then have a timeline to move towards an all-payer approach where these adjustments done on an all-payer basis using all-payer patients. The next three are new performance programs for the AHEAD. The first one is, as I already alluded to, is a health equity improvement bonus. This is a positive adjustment up to 2% if a hospital improves the quality of care for the most disadvantaged populations that they serve. The condition is that they also have to improve overall quality, and then there will be a sub-analysis for the patients that are coming from the most disadvantaged areas and have those dual eligibility status. The third one is the total cost of care adjustment. This is again, plus and minus 2%, tracking the total cost of care for the beneficiaries living in a geographic area. And the purpose is it has couple. One is this is kind of a protection against shifting hospital costs to community providers. As we discussed before, The hospitals will be incentivized to look at their own services and then be part of the delivery health reform. But if the services shifts to other providers and overall cost goes up, they will be kind of accountable for the total cost of care, and that's kind of protecting the incentive to shift everything to a non-hospital setting, which will then trigger this adjustment for the hospital global budget. Another aspect of this is that as you all know, CMS provides additional funding to practices who are participating in advanced alternative payment programs. And for an alternative payment program to classify as an advance, they have to have a total cost accountability. So this is not a done deal. So the practices would need to be linked to the global budget hospital, but this will open an opportunity for creating programs or other venues for the practices to become eligible for this additional funding through their own program, which is called MIPS. Lastly, CMS has an effectiveness adjustment program. This is a negative adjustment up to 2%. So this looks at the potential avoidable utilization and reduces the hospital budget based on the proportion of the avoidable utilization hospital has compared to statewide average. The intent of this adjustment is to incentivize and focus hospitals more on hospital utilization on the avoidable measures. That's kind of additional incentive on top of the global budget. So we are going to go into a little bit detail, and I'm not going to go through a lot on this one, but if you are interested in what the quality measures and programs are for the CMS side, these are kind of sample measures that they use for critical access hospitals and for acute care hospitals. So for critical access hospitals, this is going to be a new quality program. These hospitals have been exempted from these adjustments in the past, and CMS is envisioning that they're going to start collecting the measures. So they are going to be paid for reporting in the first 2 years of the program, and then they are gradually going to move to a positive side only, and then a full quality-based program towards the end of the AHEAD model. And you'll see that acute care hospitals have more formulated programs, various programs, and those are not changing in the AHEAD model. Health equity bonus, there are only 2 measures that are used for this. So the calculation is similar to the social risk measures. And then on the performance measures, they will be looking at hospital-wide readmission. So this is a patient coming back to the hospital within 30 days, excluding planned readmissions. And the PQIs, prevention quality indicators, a composite one that tracks the chronic condition. So they will be looking at the difference between most vulnerable populations, most underserved populations versus others. And if the hospital is closing the gap between those 2 populations, they will be eligible for the bonus payment, which is up to 0.5% per year.
Sorry, Shule, I'm confused a little bit. Wait, I thought that was based upon the percentage of dual eligible patients or something.
Dual eligibles as well. Sorry, it's the Area Deprivation Index, ADI, dual eligibles, and Part D. So the scores we are calculating to distribute social risk adjustment for 2% on an annual basis. Those same patient population here, we are tracking their quality.
Okay.
So the next one is total cost adjustment. There are a lot of details on this one. So as I mentioned, this is creating accountability for total spend. And in the CMS methodology, it includes Part A and Part B. So this is hospital, inpatient and outpatient, physician, clinic. The only thing that is excluded is Part D, which is the drug retail pharmacy that CMS covers in the Medicare program. Once they calculate the total spending, it will be adjusted for HCC, which is hierarchical chronic conditions. This is the risk adjustment methodology CMS uses for all of their programs. So it's going to be risk adjusted. And then they will determine a growth rate for the total cost, looking at a benchmark, which is a comparison. I'm going to run through the CMS first, and then maybe we can come to the Vermont considerations. So how do we calculate the TCOC for a hospital? It will not be based on patient level attribution. It will be based on geographic attribution. In the CMS methodology, hospital is going to say, these are the zip codes that are my primary service area. So those will be selected as a geographic attribution. And from the state perspective, CMS is envisioning to look at unclaimed zip codes and distribute those to the nearest hospital as well. I must point out that the CMS took this methodology from Maryland, where all hospitals participate. I'm expecting that the CMS may have some revisions to this methodology, since in other states, they are not expecting to have 100% participation. So the way that it's written is that if they distribute all unclaimed zip codes, that would mean that all state will be attributed to one hospital if only one hospital is participating in the AHEAD model. So because of that, I think I expect that the CMS is going to rethink their attribution methodology. So they measured, they risk adjusted, they calculated those from the zip codes hospitals selected. And then for benchmark, they will be matching those zip codes to a national counties. So this will be done statistically, and they are going to look at the demographic factors to find the similar counties in the national non-participating areas to calculate the benchmark. So then the growth rates will be tied to those counties that they found in the national comparison analyses. As they are looking at the performance, they will be excluding the enhanced primary care payments and the transformation incentive. And once they do the benchmarking, the financial impact will be up to 2% of the global payment. And the first year that they are going to do this is the second year of performance. So if we start in 2026, 2027 will be the first year. But since it takes time to accumulate the data and put it into the global budget, the first year of the financial impact will be performance year 4. As they start this program, initially it will be an upwards only. So only if the hospital is lower growth rate, they are going to receive additional funding in the first year, and then they are moving to a upside, downside only one for PPS hospitals in performance year 5, and the critical access hospitals and social net hospitals will have one more year for an upside. And then in year 6, they are moving to reductions as well as the upward adjustments in the total based on their total cost performance. Let me see if there are any questions.
Yes, Shule, can I ask a question on that, just so I understand? So conceptually speaking, the TCOC adjustment is there, one, so that if a hospital, basically if a hospital, if the hospital service area cost of care is increasing at a rate greater than the benchmark, they could get a negative adjustment. And the idea of that is to encourage hospitals to provide low-cost care for their patients and not shift care out of the hospital to other settings. Is that correct?
That's exactly correct, Dave. And maybe one more thing, like proactively, they could also partner with other providers in the area as well, right? So this is the incentive for hospitals to consider what is happening outside of the hospital from the financial side.
Okay, and then so for the first 6 years, 5 or 6 years, depending upon the type of hospital, there's only an upside benefit to that. So if the total cost is lower than the benchmark, they can get a bonus.
Yes. Yep.
And then after that point, if the total cost exceeds the benchmark, they could get a negative adjustment.
Correct.
All right, thanks. Sorry, I just trying to.
Yep.
keep
But
this
the
straight in my head.
measure itself, right? The measure is the second year of the program. So in their performance will be measured on the second year of the program, but they are not getting that financial payment in year 4. So there's a 2-year lag between when we measure their total cost, they are above or below, versus how much time it takes CMS to put it into the global payment.
And this
So
is
they're not going to see the impact.
And this is a Medicare total cost, not an all payer
Yes.
total cost.
Correct.
And the complexity of this, I think, and we've talked about this, I think, in other settings, is the certain zip codes, certain HSAs. So service area, residents living in zip codes selected by the hospital's primary service area. So this gets complicated for certain hospitals, like the classic one that comes up is Mount Ascutney, whose HSA extends like an hour drive north of Mount Ascutney and not very many patients.
Yeah.
Yeah. So we kind of, I think, tried to figure out how to adjust the attribution.
Right.
But I don't see that reflected here.
So that was the CMS. So let's just then go through the Vermont's considerations so far. As we thought about performance, we considered having corridors. So it's going to be a point estimate, and corridor means that they have to be exceeding the benchmark by a certain percent to get the financial impact. So that kind of moderates some of the risks and fluctuations in the total cost. Attribution, as they mentioned, we started using hospital service areas. And for hospitals like Kasnetny, sorry, I can't never pronounce one, that we could also look at smaller geographies. And there's a slide coming up to see the percentages that we've been looking at. On the benchmarks, comparing to national counties is unknown at this point, how CMS is going to do. And I remembered from the NORC evaluation of the Vermont all-payer model, they had a point that they couldn't find match counties easily for Vermont, given how unique Vermont is with its rurality. So, there is a risk not to be able to find comparable counties. There's also a risk of unknown. You don't know what's going on in those counties in their own healthcare reform. So for that reason, we could tie the benchmark to state policy, state considerations, rather than using a national benchmark. On the excluded payments, CMS has been very limited. There are additional adjustments that will be made or contemplated. So the question is, if you do not exclude social risk adjustment, in a way, if you give 2% to a hospital that is caring for the most underserved population, when we do a total cost adjustment, that 2% will potentially be at risk, right? So the consideration is to not include those additional adjustments for those hospitals. We talked about Vermont Transformation Incentive, which will be added to the baseline. That would also be considered as excluded, if you could. And the Blueprint SASH CHT payments that would be paid through a global payment would also need to be excluded from the TCOC. These are all depend on how CMS is going to look at these exclusions. So I'm putting them as potentially potentials or things to validate in modeling as well. Since we didn't get too far in the TCOC with the tag and other stakeholders, it might be simpler to align the rest of it, maximum 2% adjustment, start in year 2 to measure the impact and use year 4, and then start with upwards and then move towards upwards, downwards based on the CMS schedule. So next slide has the HSA, but go ahead.
Sorry, I was going to ask about the adjustment, but I'll wait till you're ready. The TCOC adjustment.
TCOC adjustment. Why don't you ask now? Because I'm going to move to HSA, so the attribution model.
So under fee for service, we don't have a cap. And as utilization goes up, there's additional marginal returns for a hospital. Why do we want to cap Medicare spending in the state when we have low utilization that we're trying to increase?
CMS is, I guess, that's a great question. I mean, I think maybe that's a good question for CMS, but from the global payment methodology perspective, they are paying additional revenues than fee for service initially, and they are expecting that the growth rate will be moderated, right? So it's not negative, but rather than growing at 5%, they are capping the growth rate to 4%, let's say. In exchange for initial investment, expectation is over time, the growth rate should be slower. So that's one. On the TCOC perspective, they want to make sure that the hospitals are not shifting everything to other providers under the fixed revenue model and then creating. So that's the incentive and the policy lever. That the hospital does the right thing. And thirdly, they are also guaranteeing if your utilization goes down, they are still paying the global budget. So if you think about the critical access hospitals where we are seeing utilization declines, they're going to continue to pay the historical amounts. Again, in exchange, it's almost like they are giving that additional revenue, guaranteeing if the volume declines, you're going to keep the revenue, and then they do have to have some controls over the total cost. CMMI, as you know, is established to create cost savings and quality improvements. For them to also create programs, they have to get a OMB OACT approval, where OACT is specifically looking at whether this program is going to save Medicare money in the long run.
So that to me highlights two things. One is Member Holmes's question about the cost benefit analysis, because I think you sort of articulated it well. There's a cap, which could potentially be a cost to our hospitals, and that they're going to be punished if they go over after a certain time. But on the other hand, there's this additional upfront investment, and we have to balance that against the additional costs to do the program. And then also there's the potential to keep money and shift money and avoidable utilization. And then the second thing it sort of highlights for me is we frequently hear already that the hospitals are being paid insufficiently by Medicare for their expenses. And so we've got to make up for it on commercial is the theory. And so if we're capping on Medicare and Medicare has a protective cap, we need to make sure it doesn't spill over to our Vermont payers. So I appreciate that answer. And I think it just highlights for me a couple things that we've been thinking about as we go through this.
Yep. So the question is on the benchmarking on whether Vermont utilization is going to grow faster than the benchmarks, right? So there is built-in utilization growth in the cap. The question would be whether Vermont would likely to grow more than what the national trend is going to be.
I think we would, but it's so difficult. I mean, just sitting here today to predict, given the difficulty in retaining nurses and hiring physicians and housing and all these other issues we have in the state. So I think if you look at our population, our utilization, we would like those numbers to go north, but then there's so many confounding factors that limit our ability to do that.
Yep. And I think in the global budget, if those additional funding is negotiated or even the 2% social risk adjustment is kind of giving additional funding from Medicare. So going back to the Medicare not providing cost. So there is additional funding that may actually improve utilization rates. But then you have to think about this limit, right? So what is doable, what is needed, and where the CMS target is going to land in a way to think about.
I think Sule and Owen, these are really important points, and it goes back to the fundamentals of this program are to try to decrease avoidable utilization and decrease Medicare spending. It's from Medicare's perspective. And our data in Vermont show that those are not our problems. Our problems have been skyrocketing commercial prices and underutilization. And this program has transformation dollars up front. Our state has received transformation dollars for 8 years, at least the last 8 years, but there has been no transformation that's occurred as a result. So I'm skeptical of a couple years of transformation money. Then we quote unquote right size our system and keep Medicare utilization below a certain level when our Medicare utilization has been very, very low for a long time. So I appreciate this part of this conversation a lot. There's just a misalignment, in my opinion, between what this wants and what we need.
Can we continue this part of the conversation in executive session? Because I think there are other things to discuss that might get into negotiations. I just want to be careful. Okay.
Okay.
Thank you.
Thank you.
Perhaps maybe, can I just ask a quick question, Shule, about the total cost of care? Looks like it's going to be geographic attribution and social risk is patient attribution. Can you just talk a little bit about that difference and the incentives that each may create?
Great question. So the social risk is going to look at their own patients, right? Hospitals' own patients. In the CMS methodology, there is an HSA component too. So they are looking at the social score of the area. They haven't aligned it in theirs. We could potentially align it, Dr. Holmes, but in this one, it's still a score. So it's still not an assignment of a patient. So if the patient is going to multiple hospitals in social risk score, they're going to carry that score to each hospital. So it's about hospital, whether they are taking care of that patient, and then they can have the same patient assigned to both hospitals in the social risk score. Overall, if the hospital is taking care of the most disadvantaged population in the ranking in social risk, they're going to show up as kind of a high adversity patient hospital, like percent Medicaid. If you think about percent Medicaid, it measures something like that, percent high deprived patients, and that hospital is going to be ranked. In the total cost, we will assign those zip codes to a hospital. No matter where the patients are going, their spending is going to be counted as a total cost benchmark. So they are going to be related, but I don't see any risks using patient level in one and the HSA level in the other.
Yeah, I think I have to give that more thought, but let me ask you this. Does the social risk assessment go down if there is a reduction in the vulnerability of the patient served by the hospital, or once it goes up, does it stay in the base forever?
I mean, that's why we asked for doing it every 3 years. So if you track the patients that they serve, which includes outpatient as well, theoretically, it shouldn't go down, it should go up. They should serve more of those patients. But if they reduce avoidable utilization, so we need to be careful how we define that measure to make sure it doesn't penalize hospitals for providing care outside of the hospital for those patients. But it should go up. I don't think it should go down.
So if the patient mix in the hospital served by the hospital changes in a way that suggests that there are fewer high vulnerable patients served, it won't even, an adjustment in 3 years, it won't go down to reflect that. Is that what you're saying?
I'm saying theoretically, the measure should not go down, right? So if it goes down, then like every 3 years, we're going to measure it. And then if it goes down, then we need to think about whether you would use the original measure or the one that is lower.
Julie, are you assuming the population itself stays sort of static in your discussion there?
Yes, we did look at the indexes, and then we did modeling, and we saw that the hospital score itself hasn't changed in 2 years substantially. But we haven't applied the full methodology for modeling to see whether the patients that the hospitals are seeing has changed over time. So the other is to do HSA distribution, right? So we can measure it at the HSA level and distribute that score based on the proportion that the hospitals receive. But that, to me, created, if you think about UVM and Brattleboro receiving patients from Brattleboro, in the CMS methodology, Brattleboro is going to get their social risk score. And that score will be distributed to UVM and Brattleboro proportionally. So UVM, if they have a 30% patients going to them, their score will be weighted 30%. And maybe this might be too detailed, and I'm happy to meet with Dr. Holmes to work through it. Geographic distribution to me is not accurate because UVM might be actually still picking up the ones who have means to go to UVM versus Brattleboro. So creating a geographic level of social risk, to me, I think has conceptual repercussions, and I didn't think that that was the right thing to do.
Okay, thank
But
you.
we could do, I mean, we can have a conversation and look at the data and then finalize the methodology.
Yeah, and I think to Member Walsh's point, it'd be really helpful for me to see what the SVI versus the ADI bring in terms of hospital-specific, adjustments. Zip code by zip code. It really would be helpful to see who has a higher index across the state based on the two different measures. And then it'll be helpful for me to think a little bit maybe with you about geographic attribution, patient attribution, how these things moved, how frequently we're going to assess them, whether they can go up and down. I think these are all questions that are I'm thinking about. So thank you.
Can I ask one additional line of questions on this, Julie? So there, when we look at the SVI by individual who has been, I believe, discharged from the hospital, which I think accounts for both inpatient, outpatient services, I assume this is a level of detail that we just can't get to in assigning these values, but I assume that we're not looking at the intensity of services that are provided. Meaning, I would think from a tertiary hospital standpoint, who's receiving patients, say for instance, we have a recent article in the Vermont Digger about how there's a significant increase in bloodborne infections due to IV drug use that are being seen at UVM Medical Center. And so patients that are transferred to UVM Medical Center for that condition from a different zip code or outside their HSA are probably a pretty high intensity level of service that they're seeing. So they might be, so I guess my question is, I guess we probably can't figure this out, but if we can, it'd be great. But I assume there's a certain group of people that a tertiary center is seeing that are probably fairly high vulnerability in SVI, but maybe a low number of people compared to the total number of people that they're seeing, but have a high intensity of services that requires long hospitalizations or potentially complex surgeries. So I assume our social vulnerability index adjustment would not account for that. Is that fair to say?
Yes, the current one doesn't. If you do proportional distribution, if you think about the percent payments for those, from that area, then in your scenario, UVM is going to get higher proportion because their payments are much higher due to complexity compared to the local hospital, right? So the same patient kind of will have just proportionally have more impact on UVM because of the care that they provide.
Okay. And then on the total cost of care adjustments, say there's a hospital service area that has unfortunate situation where many patients are then being transferred to a high-cost hospital, not a high-cost hospital, but a high-intensity of service hospital that can do specialty care because say, this example of bacteremia and maybe needing CT surgery or long hospitalizations with IV antibiotics, those would then increase the total cost of care and the HSA that the patient is from, but the hospital in that HSA is sort of unrelated to the care that's being provided for those patients.
Right, but remember, we are going to be looking at growth rates. So they've been doing transfers in the historical period. So if suddenly they close a section of the hospital and start transferring these patients to tertiary care, their growth rate is going to go up. So that's the difference between what they normally do versus what they may do under the model.
Okay.
If
So
they start transferring more.
So it's trended off a growth rate, it's
right.
Trended off a rate of change.
Rate of change. Yep.
Okay. Thanks.
Good questions. All right. So the next one was to give you, so we kind of have to solve the attribution problem for total cost in addition to deciding on all other factors. If you go to the next slide, please, you'll see the so this is a heavy data table. So what you see here is by hospital service area. We looked at the highest proportion Vermont hospital in terms of spending. And what you see here is for Barre, Central Vermont Medical Center is the highest proportion Vermont hospital, and they have 58% of total hospital payments for Barre residents. Right, so they have more than 50% of hospital payments. So for Central Vermont. Then the next column is we looked at all Medicare payments, so Part A and Part B for Barre residents. And for Central Vermont, we also included their physicians to the best we can. So Central Vermont's payments for Barre is still 42% of that area. So Barre has a large market share, if you think about it that way, in the hospital domain with 58% for Central Vermont, and then 42% on the total cost as well. So if you are thinking about the total cost and how much hospital can impact, if you think about that way, Central Vermont has 42% for Barre residents. I would appreciate if somebody repeats back. Go ahead.
Yeah, so Shule, can I just sort of repeat what I think you're saying?
Yep.
So I think what you're saying is So for example, most folks, if they need expensive care, they're going to go to Dartmouth or UVM. So when you're looking at a percentage of total cost in the local HSA, to Dave's earlier point, you're going to be capturing lower acuity and less expensive care. So what we're trying to look at here is how much of the total cost is sort of done at the local area. So not necessarily total amount of services or where the person gets the majority of their care in terms of how often they go, but in terms of the actual total cost.
Yep.
So the idea would be to ensure that the hospital is, so the local hospitals, the smaller hospitals aren't sort of held accountable for care, tertiary care essentially, or care at other hospitals. How is that? Just making sure
Yeah.
I understand.
That's right. So if you take Randolph as an HSA, their local hospital, Gifford, only has 31% of hospital payments, right? Majority of the payments are to other hospitals. So as we are thinking about assigning Randolph to Gifford, we need to consider that Gifford only has 31% of hospital payments for those residents. As you compare the two columns, there are not that different, except if you look at Burlington, obviously, majority of the hospital payments for Burlington is at UVM. And when you look at total cost, it's about 57%. So there are other providers in Burlington providing care to Burlington residents. So for other places, the numbers are not that different between hospital versus total pay, but they are still kind of less than 50%. So the idea is that could hospital impact the trend of total cost if they have a very small footprint. So Madhukasne is the one that is kind of, as we talked already, they only have 5% of hospital payments for White River Junction because a lot of them are going to Dartmouth. So for some hospitals that have a lower footprint, we could look at a smaller geography to get this as high as possible. But also as we look at the trends over time, we could look at the hospital's trend, so hospital and their physicians versus non-hospital trends and have adjustment factor if if the trend on other hospitals is increasing in a way that the our community hospital have no impact. So it is complicated, but this is not as easy as assigning a HSA to a hospital and holding them accountable for all the care provided at that HSA. So we have to figure out how to do this gradually.
I have a concern on this topic, which I do think we need to be very careful about, even if these are small incentives that are built out in this, to say a hospital, let's look at NBRH and St. Johnsbury. Say if it makes sense from whatever perspective, state perspective, regional perspective, for them to increase the services provided at that hospital, and they ended up with increased payments to their hospital, but it may be more we just have to figure out how to balance this, right? Because they could get increased payments to their hospital. They could have increased percent of payments to their hospital, but they could actually, I guess if they have decreased overall total cost of care, they could still end up potentially benefiting, right?
Right, because this piece is just like, how do you connect the dollars to an area?
Yep.
Your point, Dave.
All right, I just think I need to
but
think through
I
scenarios
think,
a little bit more.
right, the cautious, then, we talked about corridors, for example, like we want to make sure this is really a trend, not a noise. There will be a lot of noise in the measure. So creating a benchmark and tying it, maybe it has to be, you know, we have a benchmark, but to receive additional payment or reduction, it needs to exceed the benchmark within certain threshold. So that's one way to think about positives and negatives. And if the concern is shift or access, depending on where we want to focus, it could be only positive adjustment, or it could be only negative adjustment starting at certain times. So CMS has created this on a gradual pathway, right? So starting with positive and starting in year 2, we may have some additional considerations given the geography and given where the hospitals are. So it could start in year 3, for example. And that would, you know, have the initial investments, access improvements already kind of captured before we apply the TCOC adjustment.
One of the things I'm just gonna want to put a pin in, because I think it'll take us down a road that I don't think we want to go down, because I know we're trying to get through this slide deck today, but this goes to Member Merman's question around market share and shifts, because one of the things I was trying to figure out yesterday when I was looking through these slides again was the market shift adjustment. And there was a line in there that talked about it depended upon whether there was an offsetting adjustment within a Vermont hospital. So I think I just want to say, you know, I was trying to go through the scenario in my head. If a Vermont hospital increases their volume by 10%, say because they hired some great new surgeon, it looked like if the volume came from a Vermont hospital, they would get 50% of the average cost, which I know we don't fully understand what that exactly means yet for that additional volume. But if the volume came from a New Hampshire hospital, they looked like 50% of the revenue as long as they achieved the total cost benchmark. So there is some interplay between all of these, and I think it depends on whether it's in-state, out-of-state, where that volume comes from, and it looks like there's some conditionality on whether they've achieved this TCOC. So that's something I don't want to derail us completely here, but I just want to say I think it's something we have to understand a little bit better, particularly for our border hospitals. What's going to happen as there's market share adjustments that come from out of state. It looks like there's some conditionality on meeting this, and I just want to think through what that means. So
thank you for pointing that out. There probably is a typo there. Market shift should track any hospital, not only Vermont versus non-Vermont. So if in your example, 10% increase in surgery, and then we'll look at the surgical volume for residents, no matter where they are. And if we establish that there's a decline either at Vermont hospital or any other hospital, that hospital is going to get a market shift adjustment. And the idea is that they will get only 50% to cover their cost because we want hospital to invest in population health, and they get more if they invest in population health, right? They get 100% on population health. They get 50% on other things that are related to markets and the competition.
I guess at some
Market
point I
shift,
got to
of course,
understand what the
yeah.
definition of population health is for
Yeah,
that, but we
that's
can
right.
move on.
That's right. Yep.
Shuley,
the
just sort of
idea-
a related question.
Mhm.
Go ahead, and I have
No,
a
no, go
related
ahead.
question.
And the other thing is, yes, they are all related in a way, like what you do in the market shift versus TCOC. TCOC is almost like a blanket measure, last measure to look at whether program is on target with the TCOC benchmarks. So that's what I wanted to say. It will include market shift adjustments in it as well.
On balance, giving these adjustments, do you see this as promoting or hindering any efforts to get more care to stay in Vermont as opposed to going out of state? We have a lot of care that goes to upstate New York or New Hampshire or Boston. And I'm just curious how this would interact with any efforts to keep more care in the state.
we didn't look at New York. We did some New Hampshire analyses, and we thought the New Hampshire spend was much higher than Vermont hospitals, given that they are academic medical center. So if we keep, and this is speculative, I think we need some data, but I think Vermont hospitals are somewhat cost efficient from the Medicare perspective. And if we keep more in Vermont, it should help with the TCOC, right? So I think it incentivizes us to bring the care back to Vermont hospitals. At least in the New Hampshire analyses, we did see that the payments there were more expensive on the Medicare side.
Okay, so
I don't know the New York one.
So there's some sort of structural benefit to getting care to stay in Vermont from Medicare's perspective. Commercial
Yes.
were significantly more expensive than New Hampshire or surrounding states. How do we attract and retain more Medicare patients that help with TCOC, but if we end up with all payer, not bring back all the commercial ones that cost more? And then there's a flip side to that, which is for the hospitals, it's beneficial for them to retain more of the high-paying commercial patients and not the Medicare patients.
Right. I think the question is, what is the strategy to provide services for Vermont residents, right? So, if it is a substitution from, a diabetes patient going to one hospital versus the other, right? Vermont hospital is cost effective compared to New Hampshire. But I think the model premise is that Vermont hospital is going to have a diabetes clinic. So that patient is no longer need to go to any hospital. So if the strategy is that one, it will work for commercial as well as for Medicare, right? The idea is to prevent that diabetes patient to get complicated and end up in the emergency or at the inpatient care. So that's, to me, is, that's the hardest thing to do, but that's probably the incentive that the model is trying to build.
Thanks.
Shule, when you look at the Medicare reimbursement differences between Vermont hospitals and New Hampshire hospitals, is that continue with UVM receiving the sole designation, sole community hospital
Community
designation
hospital.
of 7%? Yeah.
Yeah, we haven't looked at that. That's a good point, Dave. I don't know what
I would
that's going to
assume
do.
that I would assume that small hospitals in New Hampshire and small hospitals in Vermont would be roughly, apples to apples for Medicare reimbursements. But then, my understanding from the hospital budget hearing last year is that UVM was discussing how Dartmouth has higher Medicare reimbursements. And I think a lot of that might be, UVM might be able to achieve that through that sole community hospital designation. But
Yes, that's a great point. We have looked the historical data that doesn't include the change in sole community hospital for UVM now. Yeah, that may have changed. And the function.
And just kind of make one comment too. I think the complexity of the in-state versus out-of-state is complicated in commercial too, because there's certain regions like, say, southwestern Vermont, which I believe, and I'm not totally sure, that the out-of-state providers in that region, Albany, may have higher price than the in-state hospital southwestern, but I'm not entirely sure. When I looked at the RAND pricing, that is what I think I received. But the rest, so it's kind of, it's I think, and it just seems like it's different in different places. Like it's complicated, huh?
Our PPS hospitals are generally quite high compared to really any surrounding area. The costs are quite a bit more, are lower.
All right, so moving on to the next slide. All right, we have one more adjustment to go through. So this is effectiveness adjustment. I'll give you the background on this one because this was in the Maryland model, when I was there, we had these discussions. Well, we have a fixed revenue model now. Hospitals have the incentives to do the right thing and reduce avoidable utilization. We don't need anything else. So we have a fixed revenue. They'll do the right thing. And the board had discussions there about whether we should have additional incentives for focusing on avoidable utilization. So if the hospital really do the right thing and focus on avoidable utilization, the financial impact is larger. So at the time, the board felt that there needed to be a focused strategy around avoidable utilization, and there should be additional incentives built around avoidable utilization. So Maryland has done that. Pennsylvania has done that, and the CMS AHEAD methodology has that one as well. So in theirs, they are calling it effectiveness and really looking at the reductions in avoidable utilization and providing kind of, if you don't reduce your avoidable utilization, you're going to get cut on your global budget. So that's kind of the concept in this effectiveness. So if you lower your avoidable utilization, your cut is going to be smaller. So that's the idea in the effectiveness adjustment. They do include the typical measures that we had discussed with you before: readmissions, PQIs, ED visits, and low value care. And then they do have a methodology, and they kind of made this as a 0.5 to 2% cut. And then it is, again, like the TCOC, starting later in the program. So for PPS, they are starting in year 2. For cause, they are starting in year 3. So if the hospital reduces their avoidable utilization in the first year, they're going to lower their budget cut in future years. So that's kind of the idea. For Vermont, we have been looking at the avoidable utilization. You're going to see the slide. You know, given the concerns around access, you may consider to start later, or actually taking this effectiveness and reflecting on the cost efficiency. You may also propose an all-payer measure that is kind of capturing the productivity as well as their effectiveness for the hospitals, and that will take a development effort, but that would kind of combine both commercial, Medicare considerations into a hospital cost efficiency and effectiveness measure. So the CMS one is very limited. Vermont has, I think, could do something different on this one, or adapt the CMS methodology as well. The next slide is an updated PAU. So the next slide is like the definition of the PAUs. They are unplanned, right, prevented to improved care, and the overuse measures are kind of decided by the medical professional societies that they provide little or no benefit to the patients, but they are still provided to the patients. Next slide, please.
Shule, could you go back,
Yep.
sorry, a slide 21? And maybe you're going to get to this, but I just was wondering, in terms of the Vermont method considerations, I'm wondering what measures you all had been thinking about with how would we measure productivity or efficiency? What types of measures were you thinking we would use at the hospital level if we wanted to develop an all-payer measure?
We really, there's so many things in the model to work through. This is the list that we talked about, frankly, you know, because of the other, but Maryland developed their own efficiency measure that they look at the cost per visit at the highest level. And they also look at the reductions in PAU, so the hospital gets credit if they reduced it. And then they do have what they don't have is RVU. I know the board is very interested in RVU. So RVU per visit, RVU per physician could potentially become another measure for Vermont. But this will require quite a bit of development work and leverage. I think you are already working on the HBR a little bit to come up with some measures. So it could leverage those works, but add it to the global payment methodology as opposed to having it at the hospital budget review process. So direct impact to payment.
Okay, and then I'm sorry, my second question is, sounds like this has been put in the CMS methodology that relates to PAUs has already been put in place in Maryland and Pennsylvania. And I'm just wondering if you can speak a little bit to its impact, its effect on PAUs.
Pennsylvania has very small cell sizes and the evaluation is not there. But if you look at Maryland evaluation, they were able to reduce PQIs a lot. Readmissions declined, but not to that extent. And ED visits also declined quite a bit. I think the theory behind is more on the delivery reform, focusing on efforts and having a common language. Having this adjustment kind of created a common language in Maryland. It wasn't one of the strategies. It was the top choice strategy for Maryland hospitals to focus from the get-go.
So it's not clear that it's because of this adjustment that you see those outcomes. It could have been confounded by other things that were happening simultaneously.
Right? Yes, yeah, because there wasn't any option not to do, right? So it is the whole global budget concept that impacted everything. So it is really hard to say this specific adjustment had an impact, additional impact.
Thank you. Yeah.
I guess
Are there, Shule, any conditions to evaluate as to whether or not this would be successful in Vermont? Because my best understanding is that the hospitals desperately want to avoid this kind of utilization, particularly in the EDs. It's in their financial incentive now, and it's been something that they've been kind of crying out for help for appropriately for a long time. So I worry that we might not have what we need to be able to do this. Is there anything in Maryland or anything you can point us to evaluate how we could ensure this could happen?
Vermont tied, I'm sorry, Maryland tied some of the funding. They had regional partnership fundings and they tied to ED, like they had so the discussion in Maryland back in the day was, do we let all the flowers bloom or do we have focused strategies? And initially state chose to have focused strategies and created partnership funding. So hospitals partnered with the local providers to focus on a specific PQI measure, ED. For example, you are right, like these are not easy things to improve. It requires community providers and strategies. And when you look at historically, the percents do not change much. So it's about, the percent PAU doesn't move. So this will be a kind of a place where there will be, just by paying, I guess I'm rumbling. Just because you have the effectiveness adjustment that they are now paid differently doesn't mean that it's going to happen, right? So that's the delivery reform strategy that the state and the hospitals need to work towards creating. What is the strategy we want to do? The payment is not going to be enough.
Can you extrapolate a little on, I'm not familiar with the regional partnership funding in Maryland. What is that?
So they created it's almost like a grant funding hospitals, and there were conditions, and I can find you detail. This is what I remember. The condition was the hospital was supposed to bring a partner to the table. So jointly, they applied for a grant to all payer rate setting commission managing the program, and they proposed an intervention or a policy or a strategy. And once it's approved, they receive additional funding through the global budget that was kind of supporting that program for the time that they proposed. I remember some proposed even like depending on where they were, some had great relationship, great ideas, some were just starting. So commission funded both ways, depending on where they were starting from. I must say, I think they evolved and they are moving towards something else now, but I don't know what that something else is, but I can find the links and send it to you for the regional partnerships.
So,
It's
so the concept was like a hospital. Sorry, Robin, you might know this. Go ahead.
I was going to say it sounds similar to the Blueprint Community Health Team and the Accountable Communities for Health Work in Vermont. Like pulling together all the different folks in the area to work together on how to approach the challenges.
Yep, and then the funding
Right.
though came from the global budget. Yep, from hospitals' global budget.
Now, did that funding, right? So I get it. So a hospital brings some community providers together and they need money to support the community providers so the hospitals can send some of the avoidable utilization to those community providers so they can handle the work. And then the money for that came out of the hospital's global budget. But what you're saying is there was additional money added to the hospital global budget to cover those costs. Is that right?
Yes.
And do we have that feature here?
So I think the way I would look at it is that the Medicare contribution, so that the 10-ish million that we're currently getting for Medicare's contribution to Blueprint in SASH, that the Blueprint Community Health Team funding is the equivalent, but I think you could also see potentially the Vermont Transformation Incentive, if there's a transformation plan component attached to that, as also a lever or potential funding.
Okay, thank you.
Shule, when we think about a hospital's PAU, are we talking about numerical data, or are we talking like numbers of cases of PAU, or are we talking about associated revenue or costs associated with the PAU? Because it kind of weights the importance, I think, somewhat differently.
Yeah, it is revenue. So from the financial methodology side, Dave, it's revenue. But
Okay.
when you think about strategies, then it turns into how many patients, right? So at the end, from the strategy perspective, hospitals want to know how many visits are we talking about, how many patients we are talking about. So, that's kind of, but the financial methodology is based on the revenues.
Okay, because
These cuts.
an avoidable admission expense is quite different than some of the low value care, like
Right.
some of the blood tests or something that are in the low value
Yes,
care.
that's right.
$10 or $15 a piece, and an avoidable admission can be tens of thousands of dollars. So, okay.
Yes.
I have a little bit of worry on this. For one, is I think that the concept of a global budget, ideally, I think, is to incentivize hospitals to reduce readmissions, reduce avoidable admissions, reduce avoidable ED visits where it's financially beneficial to do so, and reduce low value care. So it's kind of doubling that incentive, which I could see being a little bit problematic on a few of these areas. Avoidable admissions by the PQA 90 includes like a patient being admitted for heart failure, COPD, or a community-acquired pneumonia or UTI. And so I think the idea there is that we'd have transformation to develop primary care systems to avoid patients who have heart failure, COPD, UTIs, and community-acquired pneumonias from having to be admitted. But at the same time, I would hate for there to be a disincentive for a hospital to admit a patient when they present sick. I just feel like there's a risk there that we could be kind of doubling the incentive within the sort of the inherent incentive within a global budget to try to, reduce those admissions, and then adding on this additional incentive to reduce those admissions. So from the avoidable admission standpoint, I get a little bit worried that, that we could get into trouble there with kind of stinting of care. And And then for some hospitals too, I think especially the small cause, the avoidable ED visits is complicated too, because it may actually be more cost effective for that system if they have very low ED volumes. Say Grace Cottage, for instance, has pretty low ED volumes to see some of those visits in the emergency department, as opposed to opening up a separate urgent care space and developing a whole nother, care delivery system. So I wonder for large hospitals, like this makes a ton of sense to me, but for this very small hospitals, I wonder if we want to kind of think about PAU differently for a CAH than for a large PPS hospital.
Shuli, maybe just a quick question that may be related to Member Merman's question. I'm wondering if, so there are multiple factors that can impact PAUs, right? As Dave just laid out, right? There's the difference between low value care and readmissions. And I'm just wondering, I know Mathematica has done extensive analysis at a hospital level on our PAUs and looked at the types of, these different categories. And so I'm wondering, to some degree, transformation is going to be needed to be able to reduce, readmissions. We're going to need to build up primary care, improve access to primary care. We're going to have to improve access to long-term care beds, mental health services, to prevent ED visits. I mean, there's a lot of transformation that has to be done. So to me, some of this is sequencing of this work, which should be done first. And I guess what I'm wondering, if the Mathematica work would reveal, if we did not do transformation, yet, or, if transformation came in a few years, it's going to take some time to do that transformation. What PAUs are possible now to reduce without the increased access to primary care, without the increased access to mental health and long-term care beds, right? What in our current portfolio of preventable utilization is actually reducible within the constraints of the current delivery system? That might help us understand what's going to be possible to slow the cost curve in the short run before the transformation takes place. Is that something that can be backed out of the PAU analysis that Mathematica has done?
Great questions. I need to think about that a little bit, because the whole idea is these are the measures that requires preventive care, right? So that requires that delivery reform. I need to think about whether there are any, like CHF is a good one that Dr. Merman mentioned, like that requires a lot of intensive care plans and availability. I'll take a look at the measure list, see maybe low acuity care that would be somewhat easier, but overall the idea is that these all require delivery reform, right? Services in the sector.
Right. And I think to some degree, this all goes to preparedness of our system for the pivot to a global payment model where the goal is to be reducing some of these inefficiencies and avoidable care and our ability to do that. So it'd be helpful to know, what are we prepared to do now? And what is going to take significant transformation for us to be able to achieve success under this model? So I think that would be helpful. Thank you.
Yeah, ED might be, I know ED is crowded, but there might be some ED visits. There are ERICs there and a couple things that may kind of give you a little bit more context what they are. Yep.
Well, I think the discussion sorry, go ahead, Tom.
Okay, thanks, Robert. So I just want to make sure that I understand how this adjustment is supposed to work. It's a downward adjustment, and it is applied if a hospital's performance deteriorates. Is that correct? Or is it comparison to to nationals or some other benchmark?
Yeah, there's a great question. There's much detail. It is not, it is comparison to the state average. So if you have a high PAU percent, let's say you have hospital has a 10% PAU and the state average is 5, the cut happens for that additional 5%. So 0.5% of that 5%. So it is a little bit complicated formula. Happy to provide that detail, but it doesn't, it's kind of based on your percent PAUs compared to the state average. So the reason why I said if the hospital reduces PAUs in the first years, then the PAU percent will be lower, so the cut will be lower, right? So that's kind of the incentive there, that if they are able to do it, then their future cut will be lower in the global budget.
Julie, I have a question, and maybe this will help. Tom, I can wait if you had a follow-up.
I think when we use a state average in Vermont, that state average, this is applied on a per admission basis. Because we have one very large system, that will drive the average. And so I just think we need to think that through, what effect that has. So.
So Shuli, I was trying to just get a sense of scope, and I went on the Mathematica website that has you have a hospital PAU calculator by state on your company's website. And the question I had was whether or not the way, if you know off the top of your head, the PAU is calculated on your website matches up with the way you have it described here.
Could you go to the next slide, please? Low value care is not in that website. Sorry, the next one. I think the data that we shared with you came from that dashboard. I need to check the PQI measure, Chair Foster, to see whether we used 90 or we used 90. There's another measure as well.
I see. Okay. And then,
but it is in general is aligned. Yep.
So the amounts strike me as small relative to the hospital sizes. So for, at least on the website, which might be different, Rutland is $3.3 million in fee-for-service, inpatient, Medicare, and ED PAU. I think UVM was $11 million.
So I'm glad you brought this up. So that website says we use fee-for-service claims. And since Vermont claims are kind of broken into split, some of are paid in fee-for-service, some of them goes into the AIPBP. The reason why those amounts are small is because of that. We just looked at the fee-for-service paid claims. So we've been trying to estimate it using the VCures, and we are still kind of working on it. But in general, I kind of said, okay, we know now we know the AIPBP amounts from the claims analyses. If you remember the earlier slides of the 500 million to 600 million. So if you apply the 11% to that amount, you get to about 60 million as opposed to 36 million that you are seeing in the fee-for-service claims. And all those hospitals' results would be different because they have a different AIPB amounts coming in.
Okay. And maybe it's not for today, but if you could walk us through an example of how this adjustment would work with an actual numbers in a hospital, it would be really helpful. Yep. Just to see how the math would work at some point.
Okay. Yep. And as we get to this list, I think Member Walsh's point was correct. As a percent, if the hospital has a large outpatient volume, the percent will be lower, right? If the hospital has hospitals, especially they have inpatient, some ED, and very limited outpatient, their PAU will be much higher. So what you see here from that dashboard, there is a hospital with 24% PAU. That hospital is a small, mostly inpatient hospital, and a lot of it is the avoidable utilization. So the percents are kind of not a function of the hospital's performance, as you all kind of pointed out, but at the same time, it could be the opportunity as well for that hospital, right, to if they were to create the ability to work with the other providers or think about doing things differently, their potential is at 24%. So depending on how you think about the PAUs, it could be an opportunity for that hospital or a potential budget cut in their global budget. I also added the slide looking at other states. The range of the PAUs is not as wide as this was my point about PAUs are not changing over time that significantly. So the highest percent PAU is in New Jersey. So 15% of all Medicare payments to New Jersey hospitals are in the three ones that we measured, PQRs, readmissions, and ED. Vermont sits at 11.3%. I pulled Maryland as well. Maryland's current rate is 11.6. And as you see, the other New England states as well. So the range is not that different, but the lowest one is in Montana, I believe, 7.3%. So I thought it will be good to see the range and how you can think about the PAU adjustment. All right, so we have some action items from the PAU, and this has been great conversation. Thank you for your feedback. If you could move to the next slide. So we finished all the adjustments. So here is the list of adjustments. One thing to consider is some of these adjustments are required by CMS, some of them are not. Effectiveness adjustment is not a required adjustment, at least based on our reading. We have some work to do on developing that based on your feedback, whether we do something like CMS or we do an all-payer efficiency measure. The call quality adjustments is the other one that we didn't discuss too much. We are still working on looking at some data for the cause, and also on the quality adjustment. We could align with the CMS, but I think the issue there is if they have small cell sizes anyway, I am not sure what the quality adjustments are going to produce. So we are looking at potential small cell sizes and whether that would make the quality adjustment irrelevant. But I'm told that a lot of hospitals in Vermont is already reporting many of those measures. You see the adjustment types. Most of them are upward or upward downward. And the amounts there is based on CMS, or if you're aligning based on the additional considerations that we had discussed with the stakeholders. So I want to wrap up with a couple issues and considerations that have been put forward, and we had a lot of discussions and we'll continue to have discuss. Just to reiterate, the global payment is a revenue model. It really tries to remove the financial barriers to invest in population health. But Maryland experience and other alternative payment experiences showed us that it is not enough, right? So if we are paying on hospitals differently doesn't mean that we can have the outcomes that we desire on the delivery reform. That delivery reform will require strategies on infrastructure support, technical assistance, and additional policy levers to achieve the goals of the better healthcare system. The concerns raised, I just wanted to kind of summarize, and I don't think we summarized them all, but these are the ones that we prioritize in a way. The first one is the hospital prices are too high. On the commercial side, we haven't developed a commercial methodology, but this will be a central consideration, and the commercial budget could have some additional adjustments reflecting on the higher prices. And the other one to keep in mind that the GMCB will continue to regulate the overall NPR, where there could be additional considerations for the high hospital prices. The historical revenue locks in the inefficiencies. So this is a matter of strategy. There could be strategies to rebalance and create efficiency measures now to reduce the hospital payments, or you give a couple years to get hospitals to reorient and work on the delivery reform, and then create the efficiency measure for year 3, 4, or 5, depending on the strategy. We are also expecting hospitals to make decisions on service lines based on not only the fee-for-service revenue, but based on the community need. So that may also impact their efficiency as we measure their cost and productivity. But as I mentioned, we do need measures, and you do need these measures already in the hospital budget review. What is the volume growth? Volume growth is very difficult to measure. In fact, you have to have case mix adjustment. You have to combine inpatient and outpatient, right? Because there is a shift from inpatient to outpatient, and those measures are very difficult to create, but it will require investment. And I believe it is a must, regardless whether it's under global payment methodology or in the global budget review methodology. Next slide, please. The concern around under fixed revenue, hospital may stop offering high cost services patients. Also there are no incentives to offer new services. Here, the potential solutions are exclusions that we discussed at the beginning of the presentations. Exclusion may moderate those risks, so they need to be reviewed from that angle. The service line adjustments that we have been discussing could also have impact on what hospitals keep, what hospitals reduce, what hospitals open as new. Additional considerations for those is, as you do service line adjustment, hospitals are going to receive additional funding regardless of the utilization that they expect. So you may want to think about what that upfront funding is versus what the fee-for-service reconciliation would be. The monitoring, we haven't talked much during this presentation, but we had conversations with TAG around there are measures that we want to pay for, there are measures we are going to monitor and track the progress and unintended consequences. There could be oversight as well, and the participation agreements, the contractual agreements to enter into global payment is used by Maryland so that hospitals in the participation agreement have obligations under global payment to do the things that the state cares and have reporting as well to the state based on that contract. So there, financial could be one, but also monitoring and participation agreement are the other tools to mitigate the concerns raised around closures, reductions, and barriers to access. Next slide, please. And then this also came up as we are thinking about the delivery reform. Hospitals are not able to control external factors. Physicians are a kind of a big aspect of the delivery reform. They are not part of the global payment, so they are going to continue to be paid on RVUs. The initial TAG input was that we should think about including physicians in the global payment. Post-acute care resources are limited. As we talked, maybe one potential consideration is to have the transformation funding focused on post-acute. partnerships, primary care, healthcare workforce. Again, global budget is not going to, or global payment is not going to solve the workforce problems, but are there strategies we could implement to create incentives for improving or increasing spending on primary care, mental health, and substance abuse? And I'm just going to finish the last one. Is that we all are recognizing the where patients live, what they do for work, and what their families are. They all have impact on healthcare and healthcare on their health, and healthcare is very limited. So providing that 2% additional social risk is really, to me, a very limited one. And how can we think about social sector and healthcare is, again, another strategy. So as you're thinking about the transformation plans under global payment, the role of social services, the role of current blueprint and other programs the state implemented, could have some input into the way the global payment is structured. So concerns are kind of summarized, and the potential considerations are a way to tie what we've been talking in the adjustments and the way that we've been thinking about the global payment methodology paper. But these are very short and limited list. So I think that ends the
So this go on.
Yep.
You just go back one slide. I mean, I think there's a lot to unpack in all of this, but one thing that just a quick question on is, to me, one of the main drivers of some of the distortion that fee-for-service does through the health economy is the RVU system for physician and small P provider, professional fee reimbursements, and so when we look at measuring productivity, I think one of the challenges has been, and I've looked into this for years, but I haven't, I'm not in your seat, that there's a lot of challenges in trying to understand how to think about not hospital provider level, but provider, those of us who provide care that's billed for under professional services, can evaluate productivity outside of an RVU model with all of the inherent distortions that are based in the RVU system. Kind of thinking more of population measures for primary care and other measures for different, it may not be the same for all parts of the system. Have you come across measures for productivity within the professional services side that are not based in RVUs, that are been developed or validated or in consideration?
I'm not an expert on the measures, especially on the physician side. I need to go back, Dave, but you're right. There are not good measures, but patients reported outcomes, for example, right? So I was thinking about that too. As we think about the productivity of the physicians or clinicians in general, if you count RVUs, you count minutes. If you count visits, you count how many patients, but you do care whether that patient is well taken care of. Did they end up at the hospital, or are they back home and continuing to their life in the highest quality possible, right? So that's the outcome. So I think, but if it is only one patient that the physician took care of and did a great job, would you still consider that physician or clinician as a productive physician? So it's a balance. I don't think there is one answer, but RVUs to me, are counting the minutes, and the measurement field have moved from that concept to more patient outcomes and kind of patient experience. And I think there are some measures coming out and they are promising, but that's we would need to go back and see where we are with the measurement.
Yeah, I think it's complicated because outcome measures, it depends on the outcome you're measuring. So if we're looking at population health outcome measures, say diabetes management over time, there's a big lag. RVUs are in some ways minutes, but they're highly adjusted minutes based upon the relative value of said minutes within the system. So they vary from specialty to specialty, and visit type to visit type. So not all visit types are the same. The minutes are not the same. And so I think trying to figure out a prospective measurement of productivity, whether that's at the board level or at the physician practice level, that's not tied to all the inherent distortions that RVUs have that value procedures far over, prevention, is going to be key to like a true capitated model, population-based model being productive over time, because the outcome measures, I think, so many of them are so delayed that I think it'd be very difficult to attribute those outcome measures to a particular subunit of the system, like a physician practice. But
right, and I think the PAUs are kind of used in that way too, right? So they are quick indicators in a way. So if you are taking care of a diabetes panel of patients, looking at their hospitalization rate is kind of used as a indicator of whether the clinician is
Yep.
managing the diabetes. So
but there's a
it's
lot of
still
complexity that you have to adjust for all the social vulnerability components of that too, and so it gets if we just look at hospital admission rates for diabetes, I think you could probably find pretty good literature that there's probably a very high correlation between social vulnerability, and so it gets really difficult, and this we're kind of getting too far on a side, but it's just so interrelated and so complex to try to look at productivity.
Shelley, before you go on to the next slide, I just want to say I think I appreciated the last 3 points here about the concerns around post-acute resources being limited, primary care care workforce is not sufficient, social and economic factors impact health more than healthcare, and the solutions on the right, or considerations on the right, have more to do with funding and additional targeted funding to address those issues, and some of which may be to some degree through the global payment, but some of them not. And I'm just wondering, to the degree that we know how much more funding is going to be needed to be able to make this work, would be really helpful. Provide additional transformation funding for partnerships. I know that that's the Vermont, part of that could be the potential Vermont component of a global payment, but understanding how much is going to be needed would be helpful. Similarly, around primary care, mental health, and substance abuse, understanding how much more is needed on those targeted areas to make this work. And, again, the social risk for the third one, there is that 2%. Is that going to be enough to incentivize hospitals to care for the most vulnerable patients that are going to be the highest cost, particularly if the attribution is not geographic based and it's patient based? I mean, I just want to think about the incentives. Is it going to be enough in that social risk adjustment to incentivize hospitals to really truly take care of our most vulnerable that live in their community? If you can go back a couple of slides, one, I think it was on slide 1, or maybe it was slide 2. Let me just see. Okay, this was, oh no, that's right. Sorry. Under the historical revenue as a base, locking in inefficiencies, the second line item there talks about the service line adjustments that remove only marginal cost would incentivize hospitals to remove inefficient services. I just want to clarify and understand, for critical access hospitals, my understanding was that when they reduced service line, they kept 100% of the revenue. So I just want to think a little bit about whether that does incentivize removal of inefficiency. I mean, does it or doesn't it? They're keeping the revenue, yes, but where does that revenue then go? So I just want to think about, it's not actually, I don't think it's removing marginal cost. It's removing the entire cost for some hospitals, right? Which may incentivize them to then redirect that money. But how do we then think about where that money goes to ensure that those dollars are going towards efficient provision of high quality services? So these are just things that I'm thinking about as I'm looking at these slides. If you can, and also I guess on that slide too, thinking about hospital prices are too high. It really, if we're going to address hospital prices being high and the high cost of commercial growth, we're really going to need a global payment methodology to be, to really understand how that global payment methodology is going to work for the commercial sector. I know that's work that's to be done, and I fully recognize that this was a lot of work to get to this point. But particularly given the slide that you started us with the proportion of dollars that are going to be under global payment significantly reduced with the adjustments that you made, earlier today, moving more of those dollars into commercial, it looked like. So if we're really going to get a handle on this and have a true critical mass of revenue in a global payment, it looks like commercial is becoming more and more important to get our hands around, and that the Medicare fee-for-service component that's going to be potentially in a global payment is now actually even less than we thought. So I guess I just want to say this piece is going to be critical to really tackling the hospital pricing, and it really, in my mind, needs to be thought about in concert with what we're doing here. So, but I just wanted to say all those things as I was looking through these slides and thinking about it. So thank you.
Great, thank you so much for that feedback, Dr. Holmes. I think the column here meant to really be restricted to global payment. You're right, like especially the last slide. We were trying to tie the methodology to the concerns, but estimating what is needed, and from the global payment program perspective, it's like what we could have, right? What is the funding available, and what we need is kind of the two way of looking at that. And on the service line, we haven't kind of finished it, but in the CMS methodology, you're right, the costs are keeping 100%. So there's no reduction for cause, and the PPS hospitals are keeping 50%. If you think about the PPS hospital dynamics or cause, to close any service, they lose 100%. And there are services that probably wouldn't be there if they didn't lose that revenue. So that's the dynamic there, to think through how much we are willing to leave with the hospital to incentivize them to close a service. The opposite is how much you take also then creates that access issue, right? So we don't want them to close certain services either. So that's a difficult balance as you think about to do it. The point here was we are expecting service line changes under global payment. And if we try to measure inefficiencies now, it may not be the same thing 3 years from now if they do the right thing. So that's the timing and how we can think about inefficiencies. There needs to be some inefficiency considerations, but do we do it now? Do we do it 3 years from now or 5 years from now, given the service line changes that are contemplated under global payment? Great comments, thank you. All right, if there are no other, I think this slide comes from earlier presentations. Again, as we are thinking about Medicare TCOC targets, some state level accountability. We focused a lot during my presentation on hospital level measures. There are additional primary care measures under AHEAD we didn't touch, and then we haven't touched the monitoring and evaluation plans. So they all need to kind of hang together in a way. So what you pay under global payment versus what you monitor in evaluate. There might be some additional considerations on, even if there is no payment adjustment, those measures could still be in the monitoring and evaluation framework, and there could be languages around unintended consequences and the implications for that from the monitoring and evaluation. So I think with that, we came to our timelines, and then I will turn to Director Berube for this one.
Great, and I think we've been through timelines, so I won't spend much time here. But basically there are a lot of components. So what we've been discussing again is just the Medicare component of a potential hospital global payment. There's certainly, as Board Member Holmes has raised, a lot of work still to do on the commercial side. And the Medicaid global payment is still underway with an expected launch date of January 1st, 25. Again, the execution of a state agreement, so kind of where all of the negotiations come together, is expected to conclude by June 30th, 2025. I'm sorry. With the total cost of care and primary care spend targets being incorporated kind of after that date. So there's still even work to do after the signing of the state agreement. But the commercial program, there's more time to kind of develop it. The requirements per the AHEAD model is for implementation to happen at the latest by January 1st, 2027. So there is some time in it. The requirement is just for at least one commercial payer to have joined. And if the state does move forward, certainly thinking about whether and when and how we update the hospital budget process and where those intersections are is going to be critical. Understanding how much revenue is going to flow through here, what the mechanics are, whether it's voluntary or mandatory will certainly play into what makes sense and what that may look like. Great, so I just want to highlight some quick next steps before shifting, I think, to some questions we have for you in executive session, and maybe Chair Foster, we could have a quick break. I'll leave that up to you, but I think any other feedback board members have, we've been collecting your feedback and questions. There's been great discussion today. I've been taking notes frantically, but if you have any other thoughts that come to you, certainly please send them tomorrow. I'll be kind of compiling all of the feedback and weaving that into the next iteration of the methods paper with Shule and the team. A full draft, again, will be presented back to the board will be delivered back to the board by the 20th, at which point we will post it for public consumption. And then I think there have been a number of proposals for analytic follow-up that would be helpful in negotiations and further on. So I'm still pulling that list together. I think there are handful more that were proposed today. So I think we'll have to prioritize and figure out kind of where we think the biggest bang for the buck will be and how we'll get that done. So I want to pause now to see if you want to take public comment now or.
Yeah, that's a good idea. So people don't have to wait. So I presume we're going to go into executive session. And so if people have public comment, we should do it now so that you don't have to wait for us to come back. So if anyone has a public comment, just use the raise your hand function. Ms. Wasserman, how are you?
I'm fine. Julie Wasserman here. I just have a couple comments today. The first one is that when we were discussing earlier today, the total cost of care performance on slide 16, it said it protects against shifting hospital costs to community providers. But that confused me a little bit because I thought that's what exactly we wanted, was to have the hospitals working more closely with community providers to shift some of the care that isn't needed in the hospital, to shift it to the community providers. Of course, primary care, community mental health, the obvious, but in addition, it would reduce potentially avoidable ED utilization for there to be incentives for the hospitals to shift care to the community providers. So I wanted to make that one comment. Secondly, Member Merman last week requested a slide on the risks and then downsides of the AHEAD model. It was slide 12. It was basically the opposite of last week's slide 12. And some of us are looking forward to seeing a slide that outlines the risks and downsides of AHEAD. And then lastly, if I heard correctly today, there could be a 2-year lag in total cost of care adjustments, which seems pretty long for the system to adjust to doing the right thing. I just want to point out that a 2-year lag is going to delay a lot of implementation of desired results. And but by the way, the myriad of adjustments in the AHEAD model are mind-boggling. So in case nobody noticed, I needed to say that. Thanks so much.
Thank you. And maybe Shule, if you could respond to that, because I think it's a fair point about the shifting hospital costs to community providers, because I think it's a bit of a nuance. To me, we want to shift some, but then we don't want them to dump care and shift other. So how does that work? If you can address Ms. Wasserman's question, that might be useful.
Sure, Chairman Owen, that's right. Without access shifting, so I'll think about the language, but we do expect that the community providers trend should go up: primary care, behavioral health, post-acute, and the total cost is the overall control, that it is not in excess, that the hospital has to consider cost implications. For example, if they close a service and they think that it will be provided at the community, we want them to think through the overall implications of it from the cost perspective. So it's a control. I'll say it's a control mechanism at the very highest level to ensure that they are, because we are going to keep some of that revenue, right? With the service line adjustments, we talked about keeping some of that revenue in. So overall, we are that's to mitigate the concern that they are going to dump all those services to the community. So it is a nuanced way of thinking through shifting to non-hospital providers and how they're going to interact. Very well point taken. So we'll work on that language a little bit and probably explain a little bit more how we see shifts are happening. And that could go into the risk slide that you mentioned.
Thank you. Mr. Del Trecco.
Good morning. Can you hear me clearly?
Yes.
Great. Thank you, Chair Foster, and actually to the entire board. This is a mountain of work, and we can't even see the peak at this moment. So I really appreciate the attention to detail and the questions. I have several pages of notes and comments and thoughts. I'll try to be very concise to not burden the group, but I do think at some point in time we need to collectively come together and work through all of these nuances because they're so very important. So I'll start by just saying and repeating, there's a massive amount of information here. I think we need to move to a point of having some hospital global budgets that are specific, that can be stress tested, and understanding all of the moving pieces and parts that we've just talked about today and the last couple of times. I think for me personally, some of the nuances of adjustments are just coming into better focus. And this is day 3 or 4 that we've had the opportunity to have this discussion. So point number 1. Point number 2, on the critical access front, I think, to be clear, and I think it's been said on a couple of occasions by board members, the Medicare AHEAD model is a restrictor. It's a model to restrict. And it seems to me, or there's some uncertainty of how the critical access adjustment of the base year, pulling the base year into the model fixes or helps our 8 critical access hospitals. It seems to me that this model is at odds with the very nature of why critical access hospitals were put into play. There's a recognition that their challenge of keeping costs tight because of their economies of scale. I think in one of the slides it addresses and speaks to fixed costs of being 80+% of some of our organizations. So I'd like to understand that a little bit more. We've talked about, is this model mandatory or voluntary, and There's not a whole lot of clarity on that. And I can tell you that there's great concern in this critical access space. Frankly, critical access, we talked about Soul Community, and then there's Medicare dependent hospitals. I think Julie Wasserman said it well. The myriad of adjustments, this is point number 3, is mind-boggling. Inflation, service lines, social risk, performance, and the many, many categories under each one. I can speak to some of the thoughts and issues, but one is inflation. Medicare market basket is woefully under what we're experiencing for inflation. There's been some recent PwC reports that talk about the pressures, not only around premium inflation of 6+%. We're experiencing more than that, but just some of the other underlying pressures. I'm not sure how the social risk items work. Performance indicators, I'm not sure how those work. And service line, I'm particularly concerned about a point that was mentioned by Dr. Holmes. Is this in state? Is it out of state? How do we look at this, and how do we evaluate it? And then there was a further point that Dr. Merman made. All these indicators tend to be lagging. How do we adjust for and identify indicators that we should need to react to more quickly? So who does that work? How do those get adjusted? How nimble can we really be here? We have 14 acute care hospitals with varying degrees of ability to manage this information while they try to care for their communities. Our area of focus, point number 4, has been for a long standing about our missions and our visions. The words dumping are a little bit offensive, I'll say. We are not in the business of dumping or not taking care of patients. That is our business, and that is where costs are born. So I think as we look at caring for our communities and keeping care local, how do we address workforce? How do we evaluate how this model benefits and improves care delivery in Vermont? I'm not so sure I've seen that at this point. I don't know what point I'm on. Point number 5, I'll call it. Chair Foster had a very important point around talking about if the Medicare has a protective cap because of the possibility that their payments are lower than the actual cost of care. How do we solve for this in this model? I think it's a tenet of what the negotiation should be based on, in addition to providing quality care and access to Vermonters. I think just artificially placing caps without knowing the implications or the unintended consequences are very significant, and we should avoid that at all costs. Point number 6, we've used terms like avoidable care, and I'm very appreciative of the board having a lot of conversation about these PAUs and what they mean and why do they occur. Again, I think Dr. Holmes was right on when she talked about how do we look at this from a continuity of care? What is the process that has to happen on the front end to solve some of these very important issues that are, I think, in our organizations where we know that this is the worst place for delivering care on so many levels. The care that we're delivering, the cost of that care, and what are those challenges? I think another important part of the evaluation of PAUs, who are these people? Are they payer mix? I think the ability for individuals vary greatly, and how do we solve some of these equity issues as we look at managing this? I think this is a little bit redundant, but who's going to do all this modeling and help our hospitals manage all of these multiple variables as we move towards June of 2025? There's a boatload of work here, and I know that you are all aware of this, but we've spent millions of dollars evaluating where we are just to this point. What does the future look like, and how are we going to get to a place where we all understand the negotiations, what has occurred, and we all can either say this is a good deal for Vermont or this is not a good deal for Vermont. So that leads me to the question of what are we voting for on June 1? Not me. What are you voting for on June 1? Is it an opportunity to explore the model? Or is it an evaluation of the methods paper? If it's an opportunity to evaluate the model, I think we should evaluate it. How could this benefit Vermont? I think I'd have a hard time of evaluating a methods paper without reaction from CMMI to say, no, this is good, this is bad. It seems like a very difficult exercise, especially in 5 days. And then here's my final points. In the concerns raised section, I understand the affordability challenge. We see it every day in our organizations, and we try to help and work with our patients to solve some of those problems. Just for context, from 2016 through 2020, our hospital rate increases were 2.8% pre-pandemic. After the pandemic, that number is 4.4%. So we have been working very hard to manage this issue. So again, I know it's a concern, but how do we manage that with creating the tenet of the negotiation, solving for and not locking in negative operating margins for Medicare to help create some sustainability through our entire delivery system. Point number 2, I think a big concern in here should be our critical access hospitals, and it's not there. Again, I think this model somewhat goes against the economics of those organizations. And I think I've covered everything, probably not. There's a lot here. And again, I appreciate the attention to detail of the board, Mathematica, and team. So thank you very much.
Great. Thank you, Mr. Del Treco. Any other public comment at this time? The board members, are we planning on going to executive session still?
I was hoping we could spend a few minutes talking about the negotiation strategy.
Great. I think we should use all the time we have. You have another slide on the actual motion language. All right, as we've done before, we found that negotiation strategies are harmed if they're made public before is appropriate. So I will move that we find that premature general public knowledge regarding negotiation of Medicare total cost of care target in the hospital global budget proposals would clearly place the board at a substantial disadvantage in future negotiations of contracts with CMS that include those items.
A second.
All in favor, say aye.
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 Aye. I also move that we enter into executive session to consider negotiation of Medicare total cost of care target in the hospital global budget proposals under the provisions of 1 VSA section 313A1A of the Vermont statutes. Attendance at the executive session will be the board members, board staff working on the agreement with CMS, board contractors from Mathematica working with the board on the agreement, and the state's director of healthcare reform and other staff from the Agency of Human Services working on the agreement.
Second.
All in favor, say aye.
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 Aye. So why don't we we'll go into executive session at 11:25. So we can just take a little bit of a break, and we'll see you all there. Thank you. Looks like everyone is back, so we'll resume our board hearing. The last agenda items are whether or not there's any new or old business. Hearing none, I will move that we adjourn.
Second.
All in favor, say aye.
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 Aye, thanks, we're adjourned.